I want to say that it is National Public Health Week.
It is.
So we want to thank our wonderful leader, Dr. Allison Arwady, the Public Health Department, and all of the people across the city that are working in public health and mounting this huge citywide effort to respond to COVID-19.
We've been saying that really, at this point, the whole city of Chicago
We're
team,
all-
but really everybody is working in public health right now.
This is true.
But it is, it is a major week for us. If we had not had COVID, this week would have been where we were talking all about our Healthy Chicago 2025 plan, which was framed as what are we doing for the next 5 years to work on the black-white life expectancy gap here in Chicago, which is, as folks, if you were watching yesterday, heard us talk about, and it's been something we've been talking about for a long time, but where we do have, even forgetting COVID, an 8.8-year life expectancy gap, racial life expectancy gap here in Chicago, where white Chicagoans on average live 8.8 years longer than black Chicagoans. And there are different neighborhoods in the city where we see that life expectancy gap be as great as 17 years. And all of the work that, in public health, where we think about, public health's not really health care. It's about the environment and the systems and the underlying causes that lead to some of those disparities. Half of that gap is chronic diseases. So where we look at that 8.8-year gap, half of it is because we have differing rates of diabetes, cardiovascular disease, hypertension, lung disease, smoking rates, asthma rates. And at baseline, that's already a big problem. It's one of the things that drives our differing life expectancies. But then when you layer that on top of coronavirus and you think about, again, who's at most risk for the serious illness, the hospitalization, the ICU, and unfortunately even the death, it's part of why we're seeing some of the racial disparities and inequities that we talked a whole lot about yesterday.
And isn't it the case that 95% of those who have died with relationship to COVID-19 had underlying conditions?
Yes, we're tracking that every day. If you go to chicago.gov/coronavirus and you click on that latest data, you'll see there's a lot more information up there now. And one of the things we're tracking is really every day that percentage. And we were at 95% of the deaths for whom we've completed investigation, which is almost all of them, have had an underlying condition.
We forgot to check our social distance.
There we go.
We're still keeping that up. And we know that it's a beautiful, warm, sunny day out today. We want to remind you to keep up all the things that you've been doing to really to save lives during this time. So we know that we might be even more inclined to get a breath of fresh air today. But we still need to hold the line. We still need to stay inside and be outside only for essential things.
You can go out, you can get a little bit of sun right near your home. I know people are excited about potentially 70 degrees, but it is not a time for congregating. It is not a time for getting together. If you are out, you need to be keeping that distance from others. This month, is the most crucial time. This is where, we are starting to see a little bit of that curve flattening. We're really pleased about that because that especially means we're less likely to see the total overwhelm in our healthcare system. But this is the time to absolutely not let up on that. We cannot have additional infections right now as much as we're able to avoid that. And we know that there are essential workers who have to be out. We know there are essential reasons people need to leave, but being as careful as you can about that social distancing, really good hand hygiene, and really protecting folks who are more vulnerable.
So bear down, Chicago. We're going to start with some data.
So I thought we would take the opportunity to actually look at some of the new data that we have available on the website. So again, chicago.gov/coronavirus, right up at the top, latest data. There is a whole lot more up there than we've had previously. Much more detail. The epidemiology team has been working, and there's even much more work than you even see going on the website happening every day to really understand where we most need to be putting resources, where we most need to be doing investigation, populations. We use this data to make decisions about how we drive testing and how we make sure we're getting messaging out, and really make sure that we're putting our resources where they are most needed. So let's actually, yesterday, if people didn't see the press conference, I encourage you to really go back and look. We talked a lot about some of our own data and how it is similar and different to what we've seen internationally. So we won't pull the maps just up yet, but know that they're coming. I think high level, let's maybe talk about our numbers and some of that data. So in Chicago, we're now at 5,043 cases lab confirmed in Chicago residents, and we're at 118 deaths. That's among 12,262 cases in Illinois and 307 deaths. And if you go to the website and look, you'll see we've put a lot more detail in about those cases. So we now divide out how many cases have been in each decile of life, each 10 years. So how many in age 0 to 17, which is 54, how many in age 18 to 29, which is 704, all the way down. We also divide out male and female, which is basically almost a 50-50 split, as you would expect. And then we have race ethnicity data on here, which was a lot of the focus. It's been a long-term focus at the Chicago Department of Public Health. It's obviously been a major focus for the city, for Mayor Lightfoot, really talking about her poverty agenda, our Healthy Chicago 2025, really being honest about the ways in which access to opportunity, historic racism, the not equal access that people have to healthcare and grocery stores and safe spaces to potentially be outside and be getting that exercise drive some of the chronic disease rates, and that in turn is part of what's driving our numbers. So in our race ethnicity data, we talked about it yesterday, but again, I encourage you to take a look. About a quarter of our cases are missing race ethnicity data. Right. And so we talked about this yesterday, and that's because the way this data comes in is it comes into us electronically. So especially where you're getting hundreds of new cases a day, the Chicago Department of Public Health doesn't have the capacity we normally would to be following up on each individual case and going into the records and calling people up. And so we get this electronically, every lab result we get. And you get a name, and you get a date of birth, and you should get an address, and you should get a race ethnicity with that. But if that data is not collected on the front end, if it's not collected by the healthcare provider who is ordering the test, or who is caring for an individual that might have coronavirus, it then doesn't come through to us. And this is it's a problem for us all the time. I think often, I'm a doctor, and you're busy, and it's hard to, you have to kind of get everything in. And I think sometimes asking people about their race ethnicity is something that people are just a little less comfortable doing. And so people they skip the boxes sometimes. You'll be registering patients in a healthcare setting, and maybe you just don't put it in. Or they'll put it in and not ask the patient, which is one of the reasons they make an assumption. And especially on ethnicity, where we look at especially the Hispanic, Latinx, we know that if people don't ask, that often gets undercounted. And so one of the things that as a city we did in response to this data yesterday is I actually signed an order, a law, that first of all required all of our hospitals to allow more sharing of individual patient information related to COVID. So our hospitals are working so hard right now. They don't have a whole lot of time to be, answering the call from the health department. Can you look up the underlying conditions for this patient? Can you follow on this? So this is a way that electronically, Rush University Medical Center has really been helping lead on this. And we're building an electronic health record that, first of all, can be used in McCormick Place for when we're potentially having overflows of patients, so that if someone was getting care in one of our hospitals and then they transfer to McCormick, you have all the records, you have the information. But also from a public health standpoint, it will allow us to much more easily know what's happening at more of that individual level. So we're excited about that. But we also put it in as part of the order, really a requirement that anyone who is doing COVID testing or caring for patients with suspect COVID include all the demographic information population, including race and ethnicity. So it's an important
really need to
thing.
understand that 25%.
We really need to understand that 25%, and we want this to be standard practice always for things in public health. But if you look at the numbers here, putting aside the 25% for whom we don't have race ethnicity data, we're only doing our percentages across the ones that do. 52% of our cases are in Black, non-Latinx Chicagoans, and that compares to only about 30% of Chicago's population is Black, right? 24% of our cases have been in white non-Latinx, 14% have been in Latinx. Again, we expect that is probably an undercount. About 4% in Asian non-Latinx, and then 7% in other, people who self-identify as other non-Latinx. So already we're seeing some difference there in cases. But then we showed some maps specifically, and I do want to take some time to really explain these. So let's go ahead and pull up first our case counts by zip code in Chicago. This is a map that we showed at the press conference yesterday. It's available on the website with the rest of the data. Please take a look. But I wanted to explain in some more detail what we're seeing here. So this is literally the city of Chicago and all of its zip codes. I believe there are 83 zip codes, and it's just a distribution of numbers of confirmed cases by zip code. So you'll see that there are 5 different shades of blue on this graph, and the darkest shade mean those are the zip codes where we're seeing the most cases. But I want people to understand it's not just that we go through and sort of rank the zip codes. So if you have 83 cases, you could say, oh, these were the 16, right? 1/5 of them. These are the 16 zip codes that had the most cases. These are the 16 zip codes. That would be sort of a eyeball kind of way, or like a, like you might do in, elementary science class about it. But we actually, the way we do it here is we do some statistical analysis of this using epidemiology software, and we look for what are called natural breaks. And this is, again, getting a little bit technical, but I want folks to understand it. That as opposed to just eyeballing it, we look at the data to say how are these statistically different from each other, and where do we really see zip codes that are standing out in either way. And so you'll see on this map that there are 4 zip codes down in the far southeast, and then there's one way up at the very north that are that darkest blue, and that's because those statistically are just in the breakpoint of software really standing out in terms of yes. And we do this, so we make these quintiles, they're called. Quintile means you make 5 breaks that sort of help you see where you need to understand where more cases are.
Meaning that it's not like it's 20%, 20%,
correct,
20%,
16%, 16% because it's a quintile. It's actually takes more into account trying to have kind of as equal numbers as possible across the zip codes, but taking it into account. So it is true for all of these, darker means more and then lighter means less, but there is some science behind that. But then secondly, let's actually take a look. People understand case counts pretty well. 4,603 cases, here's where those cases were. But now let's take a look at the next map, which is case rates by zip code. And this one, honestly, is a little bit more of what we use from an epidemiology perspective. But I wanted to take a few minutes and explain it. And again, if people have questions, we'll probably keep explaining this because it's just really important for people to understand. And if you think about it, the case count by zip code can have some problems. If you have a zip code where a lot of people live, you will expect to have more cases in that zip code. And if you have a zip code where fewer people live, you will expect to have fewer numbers of cases in that zip code. So the reason that we look at rates is it lets us take into account the differing populations in the zip code. And that's actually a better way to compare. Right. And so what this is specifically, it's a case rate per 100,000 population among Chicago residents. And that can seem a little weird, but that's a standard way that in epidemiology we use to compare. And so for the case rates, if you look over on the left, we've got the same quintile idea. So we've divided it into 5, not equally, but based on those breaks that show us where there are parts that really are standing out either in good ways or in bad ways. And so you can see that in the darkest blue, we really just have 2 zip codes. It is still that same one up north, and then there's one right in the middle, 60612, that are standing out as our highest case rates per 100,000. And the numbers for that, if you compare the dark blue, it says 312.4 to 479.3. The numbers don't matter as much, but what they mean is that between 312 and 479 people per 100,000 people in that zip code have coronavirus. And so it's just a standard way to compare. But really, this is where we look at it. You see that down on the south side, the far south, still we're seeing pretty high case rates down there. And that is a less populated area of the city by and large. But it tells us that remains an area that we definitely need to focus on, and we have focused on. We're not going to talk about the testing numbers and rates today, but I encourage you to look at those on the website too. And we've done work to really make sure that testing rates are in the areas where we've seen more cases. We've done
our testing map kind of matches up with our count.
Yeah,
map.
more or less, and
Yeah.
we use it to sort of to push those resources. We have more tests. We have more cases in African Americans, but we also have done more tests. 44% of our tests have been in African Americans. So I want people to understand that we do use this data to really drive resources and investigations. But
I think the interesting thing here is if we look at that far south side, whereas when we were looking at counts, the southeast side in particular was one of those darker blues. But then when we come and look at case rate, it's not in that darkest blue category. So
it's right. It's still in the sort of second category, but like that 60617, which is the one all the way on the right, it was in the darkest blue in the first one. We have a lot of cases in there, no doubt, but it's an area that has a relatively higher population, and so you want to kind of correct for that population. And so certainly every one of these numbers is a case, right? And that's where, putting some of the human faces on these cases, and we talked where we've done some of these cluster investigations, but we do use some of this. And so yesterday when we were talking about what are we doing about some of these inequities, it's about really making sure that we're directing education and resources and connections to community organizations and faith-based organizations, and really wanting to focus on vulnerable people especially, and ensuring that they're being supported in all the ways that we can to both educate and protect, that there's work happening in businesses that are in these particular areas to make sure that, for example, if there are grocery stores or corner stores, are they doing all the same things that some of the grocery stores or corner stores in other parts of the city? Do they have the same cleaning and the same social distancing and the same thinking about numbers? We work to make sure, for example, the mayor talked yesterday that the CTA, our transit, which, we have a lot of essential workers who live in these areas. That's part of the conversation about, why do you see differing rates? And
we've talked a lot about lived experience,
right?
And how social distancing might be a challenge if you're in a multi-generational household, or if you have a couple of people who are actually moving in and out.
That's right.
Because they have to work.
Exactly. And so this is where, really working to see where are we seeing a lot of ridership still, getting bigger buses, spacing them out, really, this kind of work that we can do at a city level to make sure that the environments in which people, when they do need to be out, we're making them as safe as possible. That's sort of a public health approach to trying to work on this. While at an individual level, we're doing the outreach and the connection, and then working with our healthcare system, obviously, to make sure that people are getting into care where they need it. So I think that's probably enough for now around the case numbers versus the rates. But I do want to take a look, and if you've got questions, put them in. Let's look at one more in some depth. I know we're taking a long time for this today, but if people have good understandings of the data, I think it helps everybody. So let's pull up actually one of the charts that is on our daily, it's on that same chicago.gov/coronavirus. The data's up there, and there's a way to download. We've put all the prior dates up, so if people want to see how things have changed, it's all up there. But if we pull the table up, is it up? Great. This is actually looking at deaths in Chicago residents. And this was where a lot of the conversation was yesterday. And, I wanted people to, again, there's a lot of numbers here and kind of have some understanding of what we're looking at. So overall at the top, you see that Chicago has had at this point 118 deaths. And then you see this line about percent of deaths within group, and then rate per 100,000 population. Let's talk about sort of what each of those mean. So percent of deaths within group refers to what percentage of people have died from that whole group of cases. So in Chicago right now, among all of our confirmed coronavirus cases, 2.3% of those confirmed cases have died. And we know there are a lot of people who have had coronavirus who have not been tested, right?
So they're not in that confirmed
They're not in that group. And we know that our death rate overall is lower than that, for sure. But it helps us understand, and where we're looking across populations, not just in Chicago, but around the world, it helps us understand, that. And then the rate per 100,000 population, that's that same rate I just described on the map. It's the standard way that we use to compare in epidemiology how much a particular subpopulation is being impacted. And so across all of Chicago, 4.4 out of every 100,000 Chicagoans have died from coronavirus at this point. And so if you take that all the way down this chart, you can kind of get some understanding. Like if you look at the age, for example, we do some basic division to understand what percentage of our cases have been in a particular age group or in a particular gender or race ethnicity. So for example, if you see, 26 of the deaths have been in people who are 60 to 69, and 51 of the deaths have been in people who are 70 plus. You put those together, 65% of our deaths have been in people over 60, and only 18% of our population is in people over 60. So as we've been saying from the beginning, people at high, in these older age groups are really at much greater risk for complication and death. But then you can also, let's just take the 70 plus, if you follow that line across, yes, that 51, that's a lot of our 118 deaths, but also you can see that 6.6% of the people who have been diagnosed with COVID over the age of 70 have died. And you can see that the rate of 21.7 per 100,000 population is much higher than those other rates. So you can say, even if you look at the 60 to 69, that rate is 9.9. That's like half the rate of what the death is for people over 70. So that rate is the best way to compare between groups. Does that make sense?
Yeah, similar to how we were looking across zip codes.
How we were looking across zip codes, right. And then the same thing for gender and race ethnicity. So if we look at our male-female here, again for deaths, it's interesting because remember we said a minute ago, our cases are split about 50-50, just maybe like 51% men, 49% women. But if we look at our deaths, see how 73 have been in men versus 44 in women, that's 62% of our deaths in men as compared to only 38% in women. We talked a little bit about this yesterday, but there are probably some biological differences in immune systems between men and women that have to do with women having 2 X chromosomes and a lot of the genes related to immunity being on X chromosomes. Women, needing to have the potential to give birth, and there can be different immunity things. Estrogen plays different roles in immunity, so there's some biological, but also we talked that, men have more chronic diseases, do smoke more, generally are not as quick to seek medical care. A lot of their chronic diseases are not in such good control, and some of that behavioral, so really messaging around if, men in particular, take this seriously.
They're a little more vulnerable.
They're a little more vulnerable. Men wash their hands less often than women do. They use soap less often than women do in normal times. There's studies about this. And so, emphasizing that, older people are at risk, men are at risk, and then this race, and everybody's at risk for infection, but this is, again, who's at risk for the death, right? And the really serious complications. And then this is where the race ethnicity, this was the really just not unexpected given what we know about Chicago, but just some of the really hard news to be sharing. Where, again, if we look at our deaths, 81 of the 118 have been in Black, non-Latinx Chicagoans. That's 72% of our deaths. But if you
So we're 30% of the population.
30% of the
52%
population,
of the cases.
52% of the cases, 72% of the deaths. And these are getting updated every day, and we're following them every day. But again, if you follow that across, that means that if you look, 4.1% of the African Americans who have been diagnosed with COVID in Chicago have died at this point, right? And that rate of 10.3 per 100,000 population, if you compare it, for example, to the white non-Latinx, we've had 16 deaths. 1.8% of the white Chicagoans who have been diagnosed have died, and that rate per population is 1.8. That's where you compare between 10.3 and 1.8, and that's about, probably 5 to 6 times the rate of death.
Got it.
Okay, so I know it's a lot, but I think it's important for people to kind of understand that this is where we talk about it, some of the data for how we compare. So everybody's interested in numbers, and we show the numbers, but these rates and these percent of deaths are some of what we follow long term, and then where we're working on messaging.
Right, and as you said, we know that these numbers are people.
They're people.
These are people's lives, and all of these lives matter.
Yeah.
And that is why, armed with this data, we're really ratcheting up our coordination and our efforts at a community level. Exactly. To really focus on this.
Right, and I want people to know that this has been a priority and a focus from the beginning, and it's a piece that we are very serious about at the health department, and where we were seeing early clusters, really working to have this. But I think you'll remember, what was it, a week ago? We were still answering questions on here about, some of these myths that can Black people get COVID, right? And so, it's really, this affects everybody in Chicago, but we're experiencing it in different ways, just based on socioeconomics, based on race, based on age, based on underlying conditions, and it's everybody's responsibility to be taking this seriously, and then to be supporting in areas where it's harder for people to social distance, and it's harder to work from home, and it's not as easy to, people don't have cars and necessarily, and just all these ways that we can take the realities of the differing racial and economic overlap in our city, and think about how that overlaps with COVID. My team is actually also doing some analysis about how economics and what we call sort of high hardship communities fit into this picture. We regularly do that, and so there will be more about that to come.
And then do you also look at kind of the relationships between, say, gender and race?
Yes, yeah.
And gender, race, and age.
Exactly, exactly. So this is this intersectionality idea, right, which gets discussed a lot. It comes absolutely to light here in this very quick way with COVID. And one of the things that's been different for the health department is how quickly we're needing, every day we're rerunning all of these analyses, and we're really committed to making sure that the data is, more normally we'll put these kinds of reports out, monthly or yearly even. With opioids, we're a little more used to doing some of it more quickly, but it's really pushing us to make sure that all of this data is being updated. Every day we're updating this, and you can look at it. And if you have other ideas for how to share some of this data or show it or other analyses, we have a lot of really strong people thinking about it. But we don't want to just sort of describe and admire the problem. We want to use it as much as we can. We've already been doing that, but for everybody to really be acting. We are going to continue to see these disparities. I want to be clear. These are built on top of just years and years of all of these underlying conditions, all of these issues. But there are hundreds of very, very sick people in hospitals today, many of whom unfortunately will probably die, and deaths tend to lag cases, and even some of this. So we're going to continue to see this, but we want to be doing everything we can to limit it, to mitigate it, to make sure that the information is out, and that we're doing everything we can to get resources and limit as much as we're able to.
Yep, we are fighting.
We are.
Okay, so let's turn to some questions.
Yes.
And this first question is actually on topic. And I think we might have answered some of it. Christian Johns on Facebook recent statistics are showing that Black Chicagoans are making up a majority of deaths
Right.
in the city. Can you explain why, which I think we just did?
Yep.
What can I do to protect family members with pre-existing conditions?
Okay, great. So I think if anything, this really, it brings home very strongly, you know, a lot of this messaging that we've had about sort of who, you know, underlying conditions couldn't be more important here, right? So I like the way he asked that, like, what can I do to protect family members with pre-existing conditions, especially if you've got people with pre-existing conditions who are also older. And then I would probably say, adding on to this, people who are, you know, who also are men, even a little more than women,
Yes.
probably. And then where race and ethnicity fit into that. I think in a lot of cases, a lot of that is more about both underlying conditions and some of just the different realities of how that may intersect with poverty, but we'll know more about that. But I think fundamentally, this is about, first of all, if you've got family members, if they're living with you, if they're not living with you, we want to be keeping people in these vulnerable groups, especially older, especially with underlying conditions, just as protected as possible.
Yes.
So
At home as much as possible?
at home as much as possible, not interacting physically with people as much as you can. Where you are living together and you're interacting, really careful with the hand hygiene, careful with the surface. If there are people that are having to, you know, go out and come in.
Isolating if anybody feels
Isolating
sick.
if anybody feels sick. If anybody feels sick, some of that face covering that we were
Yes.
talking about with having the cloth over the mouth. And then anyone who has these underlying conditions, not waiting, you know, if you know, we've had on there from the beginning in that group, we absolutely want you reaching out, you know, calling, and then if people are needing care. I think it's also worth reminding people maybe about some of the quarantine and isolation
Yes.
facilities that are available. So, you know, we've talked a lot. There's a lot of different things happening with hotels and McCormick Place and all of this. But from the beginning, we've had in place the ability for quarantine and now especially isolation, where if people are at the emergency department, even if they don't get admitted to the hospital, or they get admitted to the hospital and then they're ready to go home, and they're at a place where they would be good to go home, but for some reason their home is not appropriate. So certainly we've done a ton of work thinking about our homeless population here, and that, I mean, we could talk about that for 20 minutes, so we won't, but lots and lots and lots of work there, very aggressive around how can we keep people more socially distanced, how can we provide settings, how can we get testing, how can we separate out. That congregate setting in long-term cares, in the jail, in those settings has been a big priority. But this also is true for people who can't return home if they
Right.
have a vulnerable family member at home, right? Like someone who is really, you've
would
got
put
someone
at
you're really
risk if
worried
they were at
about,
home.
that you'd put them at risk. There is the possibility to be able to, you know, again, you have to, at least the way it's set up right now, you do need to have a medical assessment first. So these hotels are not, you can't call up a hotel. That's not the way it's
can't
set up
admit
right now.
yourself to it.
Because the problem is if you're sick, these are really designed for people who we know are likely to be sort of stable and okay to be at home. These are not places to really be getting medical care. As we think about McCormick and some of these other settings, there's more possibility there. But if you're sort of deemed appropriate to be home and you're waiting for a test result, for example, or you're positive and can't be home, that's where the hospitals and the emergency departments, you know, have these COVID discharge coordinators, and there's the possibility, and we'll build up additional capacity for that and be thinking about how to do that even more. So
every hospital has these steps that they can take.
has these COVID discharge coordinators, and they should be really assessing as people are going either out of the inpatient setting, meaning they've been admitted, but also even out of the emergency department. And we're trying to support the hospitals. Again, it's like a lot of burden on the hospitals right now, but in terms of trying to make these processes easier, and making sure that we're doing what we can to provide space.
So just building on that,
Yeah.
if I have a family member who has an underlying condition, say my grandmother has diabetes, but she's somebody who is used to being out and taking care of herself and independent, lives at home, but Should I be suggesting that she shouldn't go to the grocery store?
Absolutely.
Should I go to the grocery store for her?
You should go to the grocery store for her. You should be. I mean, we showed some early on. I remember one of the pictures we showed. I think was someone who had literally like parked the car behind older mom's car because mom kept going out a lot to coffee and visiting people and social, and I think there's less of that going on broadly, but yeah, anything you can be doing to support older people with older underlying medical conditions so they can stay home is just one of the best things you can be doing. And then being careful where there are multi-generational families and essential workers who are out, as much as you can think about that, the better. There's also been some actually interesting conversation, and the health department's been putting together some language that if there are people who, like maybe you have older family who might be in congregate senior housing type settings, that we know there are a lot of people who are home, right? Like people who normally might be out and working, but they're home. That if it's a possibility to potentially, even in a short-term kind of way, where it's safe, maybe bring, mom or dad or grandma, have them come home with you, even out of some of these congregate settings in a short-term way, if you're able to help provide that care and it's safer. I mean, this is always sort of a balancing act. A lot of decision, and this isn't for the people who are very, needing a ton of the hands-on care that people can't provide. But there are seniors who live in relatively independent kind of correct
what we would call congregate
type settings, and if there is some capacity to potentially, in a short-term kind of way, think about maybe having those folks not in congregate settings. We know that's not possible for everybody, but it is something. When we talked to New York about, did they have suggestions? That was one of the things they said they wish they had thought about a little bit earlier, and emphasized that just if it's possible, it might be something to think about doing, where again, you may have people at home who can help provide more of that support if they themselves are not needing to sort of go out and be essential workers than you might otherwise. So just something to think about. It's not a requirement, it's nothing like that, but an example of another way
how we can care for
how we can
for
potentially care, again, depending on your living situation. Yeah. We know it doesn't work for everybody.
Okay. Denise Sims on Facebook is asking, how can we download the COVID-19 testing chart that you displayed at the press conference with the mayor?
Yeah, so that's chicago.gov/coronavirus. Right up at the top, latest data. You can download everything we showed today. You can download everything from the press conference. Actually, what's up there today is even more up to date than what we showed at the press conference, because we've already updated it since then.
And those get updated every afternoon?
Every afternoon we update those. The governor at 2:30, right, does the press conference where they sort of give the state numbers. And then sort of shortly after that is when we post our Chicago-specific numbers, and we are putting a lot more analysis up there every day. So it's in the afternoon that it goes up, and you can track it every day.
Okay, so speaking of testing, we have a couple of questions here related to testing. Judith Nelson on Facebook, how soon do you think an at-home test to determine if you have COVID-19 will be available? And Francisco Solis from Facebook, how long does it take to get test results back, and is that new Abbott quick test already in place?
Okay. Yeah, so testing is a big topic.
Yes.
Let's hit it just high level today, and maybe tomorrow we can even come back and do a little bit more, because it's really important, really complicated, really interesting. So first of all, to those specific questions, the Abbott quick test, there's been a lot of attention to it because this is the test that has been FDA approved and can give you in really less than 15 minutes an answer sort of on the spot. And that is available in terms of there are some machines, including here in Chicago. The mayor was on the phone just yesterday, I believe, for example, with
Abbott's right here in our backyard.
Yeah, Abbott's here. It's been a big conversation. Still, though, what we're lacking is a lot of the things that go along with that machine. So there are the test kits, they're called, which are the reagents and the cartridges, the sort of things that you use up when you do a test that we also need from Abbott, and everybody needs those. And so that's one piece. And then the other piece is that we still are short on basic things like swabs. The swabs are not made by a particular company necessarily, but the places where these swabs are made normally, they're in Italy, they're in China.
Yeah.
The whole
The
thing
supply
has been
chain has
disrupted.
really been disrupted.
And so for any of these clinical tests, there's been actually really nice work being done among a lot of our hospitals and researchers here in Chicago to figure out, are there other kinds of swabs we can use? Can we think about saliva and nasal swabs instead of the NPs? But still, the swabs piece remains a gap. Not just the machines, but the cartridges and the other pieces,
accessories.
the accessories that you need for that test are very much in short supply. And so trying to get those, we've been trying to procure them, we've been trying to get them donated. There's been work at the federal level to try to get them. But
Everybody is working on this.
everybody's working on them. And so there's the standard, what's called PCR test, which is the nasal test that is the most, the one that we need the most for diagnosis. There are additional machines now that can do hundreds of those in a day, so there's been progress there. But again, we're low on some of the basics, right? We've been saying this from the beginning. We have the special ingredient to make the special cake, but we're missing the flour, we're missing the eggs, we're missing some of the standard pieces that we need. And then the question about the at home, that's really more about antibody testing, is what we would think about. And so that's where, that's the blood, that's a finger prick. So like a diabetes test or a pregnancy test, something that doesn't have to be done in a lab as much, but it's looking for your body's immune response. So it's not so much for like clinically testing, do you have COVID right now? It's like, have you been...
Has your body responded to
Has
the
your body
virus?
responded to it? And there's a couple different kinds of antibodies. Maybe tomorrow we'll take this on as a little more detail.
Well, that's interesting.
It's really
because
interesting.
If you've recovered from COVID,
Yes.
You would show up as a positive on the test.
You would show up as a positive antibodies showing that you had been exposed and had recovered. And we've talked about, there's questions still about how long that response lasts. Is it total immunity, partial immunity? But that's what we'll be doing on a population level, where you're thinking about testing hundreds of thousands of people, and you're using some of that testing data to decide when you come out of stay at home and how you open up different parts of the population. So I think these are great questions, and maybe tomorrow, we did so much on the epi and the science today, we'll dive a little more into it.
Okay, yeah, that's a teaser.
A teaser, a teaser.
A teaser on tests.
Yeah.
Okay, well, we have a couple minutes left.
Okay.
We usually like to kick off the last minutes with some good news, especially given these last 2 days, which have been super sobering and really just sad.
Yeah.
Tragically sad. We are really excited, though, that the Lavin Family Foundation has given a generous donation to feed our healthcare workers who are working the third shift in our safety net hospitals, which are some of our smaller hospitals serving many of our communities that often are stressed from these social economic stressors.
Right.
And so we're really appreciative to the Lavin Family Foundation for that generous donation.
Yeah, and I would add, sort of along that line, we've seen some really nice examples of community groups sort of right in the areas where we've seen a lot of cases, for example, even if we haven't seen a lot of cases, really these individual efforts of what can I do on a very hyper-local level. So for example, Alderman Silverstein up in the 50th Ward, way up at the top there, again, where we've seen some cases there, and the Devon Avenue business groups have pooled their resources to buy meals from area restaurants and then donate them to local fire stations, police departments, again, hospitals, thinking again about how can we be supporting. There's all kinds of essential workers, but especially first responders, healthcare. Just last week that group had 175 meals donated to those groups. And it's a nice hyper local, what can I do to support businesses, think about who's at need, and the kind of work we want to see. I also would just add, I think I know we've had some questions in from children over time, and I want you to know that we're going to follow the lead of, I think New Zealand did this, but we here in Chicago, we are absolutely declaring that the Easter Bunny and the Tooth Fairy are essential workers. So not only do they have magic powers that completely protect them from coronavirus, but they're essential workers. They're allowed to be out and about and doing their important work.
So the change should still appear under the pillow.
Yeah. So however those do or do not play a role in your family, recognizing they don't play a role in every family, but for those who they do, you can let your kids know that not only do they have magical powers that keep them safe, but they're essential workers and they're allowed to keep working.
You're messing it up for some families out there.
I know. Well, depending on what your family feels about that. And then I think let's maybe just end with a picture. Again, please do be sending us in pictures. This was just sanitation workers, putting up a nice sign. I know we've seen examples of just how to support all of the many other kinds of essential workers.
Yes, there's so many people out there who are going to work every day.
Exactly. That we talk a lot about the healthcare workers. We talk a lot about the first responders. Obviously, that's a lot of the group that we're the most concerned about keeping highly protected and are dealing the most directly with patients.
Keep our grocery stores open, our banks, our gas stations. People who are sanitation is still helping us with
keeping the lights
streets.
on, keeping the streets going.
They are essential responders.
Yep. And so I've liked examples where we've seen. So thank you to the person who sent that in. And please do continue to send images from around Chicago, good stories. We love the way that Chicago has been stepping up. And while we continue to stay home and save lives, ways in which you're able to support whether that's financially, whether that's virtually, the people who you already know and need to support in your life, and where you have the opportunity to connect in a non-touch way with others who could be using some support, and thinking about how to do that in a local way. We'll be highlighting more examples.
Yeah, and I just feel compelled to say we've talked a lot about feeding people.
Yes.
We have wonderful relationships with the Salvation Army and the Greater Chicago Food Depository, and they are feeding so many people right now who are food insecure and reaching out. So if you feel compelled to give, those are two organizations that really need our support right now because the needs are rising, as you might expect.
Yeah, we keep on the website some examples of some of the strongest need groups that are just doing amazing work, working with the city and working with philanthropic groups and on some of these community-based organizations. So if it's been a little while and you do have some resources, take a look on chicago.gov/coronavirus and think about if you have some potential to financially support. Other than that, enjoy the sun, but in a near home way that does not put you in contact with others.
And in a within household way
as well. And in a within household way as well.
We'll be back tomorrow at 11. Alexa James, who is the CEO of NAMI Chicago, and which is the organization that runs the mental health hotline, will be here to talk about mental health issues.
Yeah, so if you've got questions about mental health and how to keep your mental health up at this time, which I know is difficult, or about individuals in your life or how to access resources or anything, please send those in so we have them in advance. And as always, we'll take them in live time as well.
Okay, stay home.
Stay safe. Save lives.